Welcome back, everyone. Today we're going to begin talking about patient assessment through evaluating the phases of an EMS call. We discussed the phases of an EMS call because throughout each different phase, there are different things that we evaluate in regards to the patient presentation and assessing the patient's need for EMS service or intervention. There are 7 distinct phases to the EMS call. There's the dispatch phase, the arrival phase, your primary assessment, your transport decision, secondary assessment and history, the reassessment, and then the patient handover phase. And we're going to talk about each of these phases in a little bit more detail as we progress through. But it's important to note that generally, every EMS call will occur in this particular order. We will be dispatched to service, we will arrive on scene, we will go through our primary assessment. We will make a transport decision about where the patient needs to go and how they may need to get there. And then we will do our secondary assessment and reassessment and ultimately hand that patient over in the continuity of care. So turning that patient over, whether it be to a physician or a nurse or another facility. So these phases do occur in order throughout our patient time, but things that happen within each of these steps may not necessarily be in the same order every single time. So while generally our primary assessment, and we'll talk about this shortly, occurs through some very sequential steps, looking at airway, then breathing, and then circulation, those may change depending on what we find when we arrive, and so we may move to check circulation first. So it's important to know that through each of these pieces, that we may move pieces up and down depending on what the needs of that individual call are. Each patient presents differently, and therefore each approach may be a little bit different. These are also the phases of the call referenced when you see certification examinations, or you may have assessments. When we look at things like question styles such as, what would you do first, right? Or what would be the first action? If your answers are referring to something in the transport decision or primary assessment of the patient, but you haven't gone through the arrival phase or the dispatch phase of the call, those things would need to occur first. So these do occur in order, sequentially through time. And it's important to kind of get a good understanding about where you are in the patient care scenario when you're evaluating those types of questions. And so a little bit of prudent real life practice there, as well as assessment knowledge for certification that you may also need to know. So the vocabulary for each of these is really important. So the first phase of the call is the EMS dispatch phase. And this occurs through what's known as PSAP, PSAP, or Public Service Answering Point. The call to service for EMS originates when a patient or a potential patient or family member or bystander initiates contact to, in our case, the 911 Dispatching Center, or PSAP, Public Service Answering Point. During this phase of the call, the dispatcher, the person answering the 911 call, is gathering a set of information from the caller. Now, this information is going to be from the caller's perspective. So it's important to understand that the dispatch is only going to be able to relay information to EMS providers that is received from the caller. The caller may not be trained in the medical profession. They may not understand all of the relevant information that's going on. And likewise, depending on the service that you're working for, the EMS dispatcher may also not be medically trained. All dispatch centers usually have a flow chart that they follow, whether they're using a Pro QA type flow chart, where they can do prompts and answer things, or they have an internal document that they're using. So they're probing the caller for answers to specific questions that we would need or we would find relevant as the EMS provider arriving on scene. But you still have to understand that the dispatcher can only convey the information given to them by the caller. This presents some unique information or unique perspective for you, the trained medical provider, when you're responding. So this phase starts when a caller calls 911, the dispatcher gathers information, and then the dispatcher sends that information to the EMS crew. This typically is done through a dispatch system via radio. You'll typically have tones that will go over radio. Some services may use a telephone. And the dispatcher will then tell you the nature of the call, usually some brief patient information, okay, and how to respond, whether that's emergent, so with lights and sirens, or perhaps it's routine where you're not going to be driving lights and sirens. The important thing for you to understand as a provider here, this is where your assessment starts to take hold. So as you get that information, as you receive that information from the dispatcher, you really should start thinking about what kind of patient you're expecting to see based on the information you've received from dispatch. So a typical dispatch information may be respond to a 65-year-old male at his residence, and they would give you the address for chest pain. Okay, so your thought process and your preparation should start now. Things that you should be thinking of. Okay, if I'm going to a chest pain call, what equipment might I potentially need when I get there? Is the address familiar to me? Have I been to this patient before? Is this a part of town or a neighborhood that I'm familiar with? We do know that certain patients in certain geographic areas have a higher acuity of presentation. And what I mean by that is in certain communities, you may have more elderly population that's more prone to things like respiratory problems or cardiac problems. If you're going to an area that is perhaps a younger demographic, you may be more prone to things like trauma. Okay, so all of these pieces should start coming together in your head as you are being dispatched to the call and as you're driving or riding to the scene of the call. Going back to one of the things that we talked about earlier, though, it's important for you, the provider, to remember that not every piece of information is guaranteed to be accurate. And what I mean by that is the dispatcher is only providing you information that was given to them by the caller, and therefore you may arrive on scene and you may have been dispatched to a 65-year-old male with chest pain, and you may arrive to find a 40-year-old male in respiratory distress, okay, or it may be something completely different. You may be dispatched out for a car accident, and you arrive on scene and find that it's a medical patient that caused the trauma, right? So you've got a medical patient that was involved in a car accident. So it's important for you to keep an open mind and not get tunnel vision, but you should start the preparation process here. The next phase of the EMS call is the arrival phase, and there's a couple of things that happen once you arrive on scene or as you are arriving on scene. For one, you should do what's called a scene survey or what we call a windshield survey. So as you're arriving on scene, you should be looking around the environment. And we use the term a lot. You'll hear the term a lot that's used about scene safety, right? The scene safe. Well, nothing is ever really truly safe, but you can look for immediate safety hazards. So, for example, in the image here, you see an ambulance that has pulled up next to what looks like to be a two-story residential building. Okay. If there were immediate safety concerns, right? If the building was on fire, if there were, dogs, guarding the gate and you couldn't get in, if there were violent encounters occurring as you arrived, all of those things would be unsafe for you to approach the scene, in which case you would need to wait for that scene to become safe before you enter in. And this concept really derives from the idea that if you, the provider, are injured, then you can't help those that are injured, right? So you need to protect yourself so that you can treat and take care of your patients. There are times, especially in today's world, where you may still have to go into a scene that is not safe or that is potentially unsafe. And what I mean by that particularly are things like active shooter situations where you may have to do warm zone extractions of patients, where law enforcement may have cleared an area for you and you have to arrive on scene and, in a relatively secure environment, there may be active activities going on nearby, but they cleared some area for you to be able to remove those patients. And there are sometimes in task force response units where You may go into a completely unsafe scene with law enforcement guarding you, and you may be going in as a medical provider. So you're going to rely a little bit on organizational policy. You're going to you're going to have to take each situation as it comes. Obviously, be in communication with dispatch and your supervising bodies during these potential issues. But as a general rule, you're going to want to make sure your scene is safe before you get there. Other things that you're going to do in the scene survey, you're going to look at indicators for things that may influence patient illness or things that may clue you into the overall patient's health, their socioeconomic status, their social health status, things that will let you know what to expect of this patient. And here's what I mean by that. If you arrive on scene into a well-kept, expensive home that maybe you've never been to the neighborhood, you arrive on scene and the yard is well kept and there is newer vehicles in the driveway, and that patient, you can make some assumptions based on that patient, or at least you are indicating to yourself that there are some things about that patient that may be relevant to you. The patient appears to be relatively affluent. They probably don't have things like food disparities. They probably have regular access to healthcare. So that patient may be in a bit of a different position than if you were to arrive on scene to a patient who has no power, right? Or you arrive on scene and it looks like the home, especially the exterior of the home, is unkept. There's trash maybe on the doorstep or on the patio of the home. There are things that tells you. That tells you that patient is probably not as mobile. Okay, that patient probably, if they're not doing activities of daily living, like able to take out their garbage, able to maintain their lawn or pay for their power, that patient is in a far more vulnerable position as it relates to healthcare. That patient may, and again, these are not facts. These are assumptions. These are propensity things that will drive your decision making, things to be particularly aware of, right? The patient who is not able to perform those activities of daily living is probably not going to have as great of hygiene, so they're at higher risk for things like infection. The patient, if they're not mobile, okay, they can't get up and get out of bed, they're at higher risk for things like deep vein thrombosis, okay? Again, a patient who may not be able to afford to have a power, then are they able to afford food? We need to be diligent and aware of a patient who may have food insecurities, okay? Because that drives the patient's health status, and those are important factors, particularly as you start to develop your profession as a member of the community. These are patients that we need to be taking care of. These are people that we need to be looking out for. And you, as a community member and a trained medical responder, oftentimes when you see these patients who don't have access to healthcare, right, or have healthcare disparities or food insecurities, oftentimes you're the only trained medical provider they may have seen in 5 or 10 years, or many, many years. And so it becomes prudent for you to be able to evaluate those things. And then particularly, even though if there's not something you can do with them, it becomes important for you to be able to convey that information so that in the continuum of care, as part of their discharge planning process, right, they can bring in some community resources that might be able to help this patient. Okay, so the assessment process really does start as you arrive on scene. You're going to be clued into things about the patient and about the patient presentation, where certain things may be present or more likely, right, than less likely than others. So it's not just about scene safety on your scene survey. It's really about taking a glance and making sure that you're getting the whole picture of that patient. One of the things that I do speak about frequently is I try to communicate to new providers and even providers that have been in the field for a period of time. You are the only person, you the EMS provider, you're the only person in the continuum of care. And what I mean by the continuum of care is You're the only person that this patient is going to see during their visit. So for EMS, through the nurses at the hospital, the physicians, through discharge, whether they follow up with their primary care physician, you're only person that's going to put eyes on the patient in the environment that they live in, or the things that, in the environment that, if it's a trauma, that the incident occurred in. So you're able to gather information from this patient's place, their geographical location, that nobody else in healthcare is ever going to be able to see. So pay attention to things that are relevant, right? Food awareness, power, right? And it sounds like a silly thing, but you might be surprised as you start your career in this field, how many citizens in the country or in county or community that you live in don't have access to running water or food or electricity, heat in the wintertime, air conditioning in the summer. So those are all things to be very mindful of, and you're the only person that's going to be able to see this for this patient where they are when this event happens. Okay, so that's your scene survey. The next phase of the EMS call is moving into the primary assessment phase. Now, this primary assessment phase really is a very short process, and it occurs within the first 2 minutes of you laying eyes on the patient. So you've assessed the dispatch information. You have gathered information from the scene. You've looked at the patient's environment. The primary assessment really starts as you're approaching that patient, right? So as I approach my patient, I'm able to determine things like their LOC, and that's level of consciousness. Okay, the LOC is an abbreviation for level of consciousness. Okay, and by level of consciousness, what we're talking about is, are they alert? Are they looking around? Are they engaged? As you walk in the room, are they tracking you? Okay, do they appear oriented? Okay, do they appear like they're engaged? Do they appear like they have an idea going on? If they're not alert, right, when you walk in the room and you announce yourself, which you should say, hi, I'm Austin with EMS. What brings me out today, or what can I help you with today? You should introduce yourself. Do they engage with verbal stimuli? Okay, so when you speak, and that would be not alert, but alert to verbal stimuli. And we use an abbreviation for level of consciousness called AVPU, and we'll talk more about this in the individual breakdowns of each of these phases and assessments. But alert to verbal stimuli, or are they, if we're talking about the abbreviation AVPU, AVPU, are they alert to painful stimuli, right? And so when you walk over and you kind of jostle the patient, or you like you're trying to wake somebody up, do they wake up then? Or are they completely unresponsive to any stimuli that you provide? Patient's not really engaging at all. Okay, that level of consciousness gives us an idea of how well their brain is perfusing and working. Okay, so that's a very short assessment technique to be able to determine how sick or potentially not sick, or not sick or potentially sick that patient may be. And the other three things we're really going to assess in the primary survey is the airway. And we'll talk a lot more about airway assessment in the airway module itself, but we're just looking for the airway being patent. And what I mean by patent is they can move air in and out. So it's not obstructed. It's not obstructed by the tongue, by vomitus or blood or saliva, things that we may need to go in and suction out. Okay. We may need to position the airway through things like a head tilt chin lift or a jaw thrust. Okay. Is their airway patent? Are they breathing? And this is really a yes, no sort of up, down thing. Are they breathing adequately, yes or no? And we haven't talked about vital signs and rates yet, but if the patient is breathing, an adult patient, roughly 12 to 20 times a minute with good chest rise and fall, we would consider that to be adequate. And then we're going to check the C, which is circulation. Okay. And we're going to do that by reaching down and feeling for a radial pulse. Okay, so radial pulse is in the wrist. And we're really looking for, is it within a normal rate, right? So is it at a normal rate and a normal pressure? And by reaching down and feeling for a pulse, we also can get an idea of the skin temperature. Okay, skin on a healthy patient should be warm, and it should be dry. So we can get skin temperature, we can get skin whether it's dry or whether they're clammy, okay? And we can feel for a pulse to make sure they have a pulse. That really is all the information that we need in the early phases to make an early decision about whether or not the patient is stable, potentially unstable, or critical. Okay. For example, if we have a patient who's awake and alert when we walk in and they're talking to us and they're engaged with us, if they're able to talk to us clearly, their airway is patent, they're breathing, okay, and they're breathing adequately. They're not gasping for air or obviously short of breath. And we reach down and we feel for a pulse, and their radial pulse is strong and their skin is warm and dry, then that patient is not sick, right? They're stable, okay? There may be underlying things that we find later that make them more potentially unstable, okay? But as of right now, they're stable. Likewise, if we walk in and the patient is only responsive to verbal stimulus, right? So they look to be unconscious when we walk in, we introduce ourselves, the patient snaps kind of awake and mumbles some words. They're not really with it. And their airway may be patent, they might be breathing, but you reach down and feel for a pulse and you have a really weak radial pulse and their skin is cold, clammy, right? That patient is definitely more sick, right? And so our decision here, once we have decided whether the patient is sick versus not sick, is the older term. I prefer the term CUPS. CUPS is stable, potentially unstable. Okay, so stable, not sick, potentially unstable. Okay, means that, ooh, something's off here. Unstable, maybe that patient that is only responsive to verbal stimuli with a weak pulse and cold, clammy skin. Or critical, right? A patient is not adequately breathing, or a patient is completely unresponsive. Gives us a little bit better of a tool there to measure instead of just sick versus not sick. Okay, but based on this information, just from the primary assessment alone, we're going to be able to make our transport decision. Okay, and what I mean by transport decision is we're going to decide whether this patient is a stay and play versus a load and go. Okay. And what I mean by that is, man, this patient is really, really sick. We need to get them to definitive care. We need to start working our way to the hospital. So prior to transport, okay, for those critical patients, the only things that we're going to do on scene is we're going to correct airway, breathing, and circulation. Okay. So if the airway's not patent, we want to make sure that we make their airway patent. If they're not breathing, we're going to ventilate them. Okay. We may put oxygen on them if they're not oxygenating well. And if there's no pulse, then we're going to work on CPR before we transport. Okay. So those are your load and go patients. And your stay and play patients are patients that are stable, okay, that you need to be able to find some more information. So this is your critical versus less critical decision here. If the patient is a critical patient and they're a load and go patient, everything else that happens will happen after we start transport. Okay. So this is usually a lights and sirens transport, which means that the rest of the phases of the call, so the history taking, the secondary assessment, all that will occur on the way to the hospital. Okay. For your stay and play patients, those are patients that you're going to stay on scene for a little while with. You're going to perhaps get a history from them. You're going to interview family members and talk to them, maybe grab their medication list and take it with you. Those patients you're going to stay and play. Okay. So you're going to have some time at the hospital, or time before you leave to the hospital. There are also two outliers for each of those as well. Not every patient needs to go to the hospital. Okay. So there are times when you may stay and play because the patient needs some assistance with their medication. They need some assistance, whatever it may be. Okay. You may be called out by a family member to help move a patient from maybe a recently discharged patient from the bed to a porta potty, or the bed to a bedside commode, rather. Those patients are just as much in need of your service, okay, as the critical patient. That's what we're there for. We are community health, okay. But those patients may not need to go to the hospital. So you have some that are stay and play that you may never transport. Likewise, you have some patients that are so critical that there are things that you need to do before you leave, and you may not get off the scene for a while. And the primary example of this is cardiac arrest. In a patient that is in cardiac arrest, you will likely be performing CPR. They're on the scene with that patient either until they come out of cardiac arrest or until resuscitation efforts are ceased. And we'll talk about more of that in cardiology. Okay. So just kind of as a reminder here, you're going to make your transport decision based on your primary assessment. Now, that moves us into the other two phases, and history and secondary assessment, which is the next one, can be interchanged around, right? So you may get a sample first, or you may, sample history, or you may get your vital signs next, or they may happen at the same time. You may instruct your partner to do one of these or the other. We're going to talk more about history and history taking in another lecture, but just to introduce the concept here to you, we use the acronym SAMPLE, which is signs and symptoms, allergies, medication, past pertinent medical history, last oral intake, and events leading up to. What I really try and encourage folks to get in the idea of is that this is a starting point for you. So it's not that you only need to answer these questions on SAMPLE. You should be going beyond, and that's why I use SAMPLE Plus. Okay. You'll also use the OPQST acronym, okay, to define some of this, and we'll go into this a little bit further with the history lecture itself. Some key reminders on this: onset and duration are different. Okay, so when we talk about O with onset, onset is a rapid onset or a slow onset. Has this been coming on for days, or did it come on all of a sudden? Okay, and then your time is how long has it been going on. Okay, so things to keep in mind as we go forward. Your secondary assessment is your vital signs, either your focused medical or your focused trauma assessment. Some key reminders here: your physical assessment is driven by your history. Okay, so when you get information from your history, you're going to use that to assess certain things. Okay, and remember that assessment involves all of your senses. So you're going to need to look, you're going to need to listen, you're going to need to feel, you're going to need to see your patient, you're going to need to hear your patient, and we'll use tools where we auscultate, and you're going to need to touch your patient. Okay, so you're going to have to use your hands. We talked about feeling for a pulse and getting a sense of the skin temperature and whether they're wet or dry, right? So you're going to need to feel for those patients as well. So you're going to use all of your senses to make sure, and even smell during certain times. So just keep that in mind as we go through assessment. Your rapid trauma assessments, and again, we'll go into this much deeper here in subsequent lectures, but it's a full head-to-toe trauma assessment. And remember that your assessments involve all of your senses, so look, listen, and feel. If you can't see it, you can't assess it. Okay, so this is typically for a patient that is completely unresponsive, that you need to get a full body assessment, a head to toe on. And we use the acronym DCAP BTLS for this, and that's deformities and discolorations, or contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. And we'll go through all this in the lab, but that's the abbreviation that we're going to use. Key reminders again: if you can't see it, you can't assess it. Okay, so you really have to, part of your assessment is looking at things, listening to things, and touching things and feeling your patient. Okay, your detailed medical assessment, these are things where you're going to really be a detective. So based on the information that you've gotten from the history of your patient, you're going to try and start looking for causes or corollary assessment findings that support your field diagnosis, your thesis, right? So you're going to start assessing for things that, if the patient's complaining of abdominal pain and you're starting to assess and you feel like this might be an appendicitis situation, you would expect the patient to have some abdominal tenderness, some rebound tenderness, particularly. If you're assessing a patient who having shortness of breath with a history of asthma, you would expect to hear different lung sounds in that patient. Okay, so you're going to use the assessment to help drive and confirm your field diagnosis. And that's important when we go to treat these patients. That moves us to the reassessment phase. A reassessment phase really should be continuous. Okay, you'll hear about the 5 and 15 rule, or 5 minute and 10 minute rule, where unstable patients should be reassessed every 5 minutes, with stable patients should be reassessed every 10 to 15 minutes. But the reality is you should be constantly assessing this patient. You should be constantly talking to the patient, engaged with the patient, watching the patient, because changes can occur quickly in these patients, and they really don't care about a clock, right? They're not going to wait till the next 5 minutes to deteriorate. They're going to deteriorate over a period of time, and you need to be clued into that. Watching things like, how is the patient's effort of breathing? How is the patient engaging with me and talking to me? Okay, so this really should be a continuous process. You may recheck vital signs every 5 minutes, but the reassessment is continuous. The next piece, or the final piece of the call phases, is the patient handover. It's really important, and we give receiving facilities, so if we're transporting the patient to a hospital, we give them 2 opportunities. We convey information to them twice. First is in a radio report. In some areas, this is called an encode. Sometimes it's just called a patient radio report. This is where we're going to call the hospital on the radio, and we're going to give them a very brief summation of information that's relevant. And that is, the information you're going to give there is patient's age, patient's sex, patient's chief complaint, their presentation when you arrived on scene, any interventions that you may have done, and then how they responded to those interventions. And it's going to be a brief sort of format. We're on scene, we're coming to you emergent with a 65-year-old male who's complained of chest pain. Upon our arrival, the patient was responsive to verbal stimuli, complained 10 out of 10 chest pain. We've administered 324 milligrams of aspirin and assisted with 1 sublingual nitroglycerin. The patient is now alert and complaining that his pain is a 6 out of 10. And then your ETA. Okay, then we expect to be there in 10 minutes. Okay, that's the general format for how you're going to do that. Most folks should have a template ready. So you should have something kind of prepared, pre-filled out, or in your head that you can convey this information to those patients or to those receiving facilities about your patient. And then you're also going to do a physical handover when you arrive at the facility. So you'll do a face-to-face turnover with a nurse or a physician. Your report is the same, but you may go into a little bit more detail. Okay, so it's going to be the same format and structure as your radio report, but you're going to go into a bit more detail so you can elaborate more about what's going on with that patient. Make sure that you give the receiving person at the facility an opportunity to ask questions, right? They may have things for you that they need to know, or they may have further inquiries about what's going on. So build that rapport with your receiving facility. And this is where, in this patient handover, the face-to-face handover, is where you really have the opportunity to make a significant difference in the continuity of care for this patient. Because remember, you're the only person that has seen them during the entire duration of the call and saw them at home or where the trauma had occurred. So you have insight into this patient's background that nobody else in the care spectrum is going to have. You also have the ability to drive the receiving facility's index of suspicion, right? If you paint the picture that this patient is having a heart attack, that's going to cue them off to start that process early, right? Likewise, if you are dismissive about the patient and give the receiving facility the idea that they're not really sick, they're just faking it, that's going to drive how they treat that patient, at least within the early part of the care. That's just human nature. So they're going to trust what you say, and make sure that you respect that trust and you convey accurate information to your receiving facility, because at the end of the day, it's all about the patient, and you are but the first step in the patient care process. And we all should be working together as a team to make sure that the patient gets the most relevant care at the time of need. All right. I'll see you guys on the next one. Thanks.